Thank you very much, Orla, and welcome everybody on this lovely evening. I hope you're not too hot and have got a nice cooling drink by your side. So my name is Gail Kinman and I'm Professor of Occupational Health Psychology at Birkbeck and also at the University of Nottingham. And I've been working in this area for quite some time, and we do know that working in health and social care is complex and emotionally demanding. And we know that employees in these sectors face very many challenges related to the job itself, but also current working conditions like short staffing, etc. We know that the pandemic has intensified these demands and brought with it a set of demands of their own, really. So the risk of stress, trauma and burnout is particularly high in these sectors, and this has negative implications for patients and service users, as well as for employees themselves. So obviously, we do need to have precisely targeted evidence-based interventions to support staff working in this type of job, to enable them to not only cope with stress, but to thrive in the job itself. So organisations, as I'm sure you know, have a legal and moral duty of care to ensure that the well-being of their staff is supported. But of course, employees themselves working in this type of work, we know it's complex, we know it's emotionally demanding. So they do need a certain degree of resilience in order to cope with the demands. So essentially, we're going to be focusing on this concept and usefulness of this resilience today, and looking at two different aspects. Now, I'm going to be making a start and providing you with an overview of research I've been conducting with Louise Grant, who's a social work academic, over about the last 10 years or so. Now, this takes a multi-level approach to helping social work organisations build emotional resilience. And then I'll be handing over to Lucy Martin, who is a GP, and she's going to be focusing on a different sector that has, similar problems, and that's resilience in mid-career GPs and its implications for the NHS. Okay, so let's just move on with my slides. You just go onto full screen. Okay, so we know that multi-level approaches are needed. So, I'm going to be just explaining what that looks like. Again, social work is satisfying, but complex and emotionally demanding, as I mentioned. Lots and lots of difficulties involved, many occupational hazards, which involves working with people who have very complex needs, who may not necessarily want you in their lives. Working with things that are very traumatic, like child abuse, etc., and safety issues. That has been intensified during the pandemic, where many social workers have been working online, which obviously is less than ideal. As I mentioned in the introduction, there is a high risk of stress, compassion fatigue, which is essentially when the emotions that you experience are overwhelming. So as a form of self-protection, you become, emotionally exhausted, emotionally overwhelmed, and your compassion for other people can actually be reduced. But there's a high risk of trauma and also burnout. Now, as well as risks to the health of individuals, this stress and burnout and trauma has been linked to current recruitment and retention challenges. But we know, from reviewing the evidence in health and social care, and I'm sure Lucy would agree here, that most interventions focus on the individual, that are trying to help the individual cope more effectively with very demanding and challenging working conditions, rather than going to the heart of this problem and looking at the causes and putting things in place to manage the cause, which is obviously the very best form of management. So just giving you a very brief overview now of our system. We were asked, first of all, to look at developing resilience in social work over 10 years ago. We started off actually probably the wrong way around, but due to the prevailing mode at the time, we were looking at individuals. So we wanted to look at what makes an individual, a resilient social worker. So we conducted several studies on that, and we will be looking at that today. But, you know, we know that we need organisational resilience to support resilient individuals. And as part of that, a resilient organisation will help develop emotionally literate leaders, which will then facilitate teams and individuals that are resilient. So it's a kind of whole organisation approach is what we advocate. So evidence-informed interventions needed at each level. So we're kind of trying to work our way through these levels. So I'm just going to give you an overview today. As I mentioned, a series of intervention studies, I'll talk a little bit more about that in a moment, focused on the individual in order to identify the qualities and the capacities of, you know, a resilient person, and also how they can be developed. But secondly, and I think, you know, more importantly, I'm going to be talking about the development of what we call the social work organisational resilient diagnostic, or SWORD for short. You know, we needed some kind of acronym and we found it. So SWORD it is. And this framework aims to build resilience, so it doesn't necessarily just focus on the individual, but at all these different levels, and support mental health and ensure that people don't merely survive in the job, but that they flourish. And, you know, we do see, and there is evidence for benefits for service users as well as individual social workers. I'm just going to give you a brief look here at an early study that we conducted, because there's so many different definitions of resilience. I'm sure Lucy would agree. You know, we've written a book on developing resilience in social workers, and when we looked at the qualities and the capacities and the definitions of resilience, this table that we included all this information on actually went over to 2 pages. You know, so there's so many different qualities related with a resilient person. So in this particular study, we looked at personal representations of resilience in student social workers and experienced social workers. And that's just really a few examples here on one of these word clouds, where we asked them, what is resilience? And we basically pulled together all these different definitions over time. So, you know, it's things like persistence, thriving, the ability to actually take up support, hardiness, effective coping, etc., being adaptive, being functional. Boundary setting also was very important, you know, in terms of emotional boundaries as well as the physical boundaries between yourself and the job. Some kind of inner strength, and learning, and things like also bouncing back. Now, this is why we called the paper Bouncing Back, because often if you ask people what resilience is, they will say that. I don't know if Lucy had the same experience. It's this idea that you experience adversity in some kind of way, and then it's almost like being Teflon coated. You know, you will sort of bounce back to your original form, and you will be unscathed. But of course, we know that resilience is more than that. You know, people do learn and develop and flourish through this experiences of adversity to some degree. But the interesting thing about our findings in this study was that social work students saw resilience as something that they expected to be taught to be. Whereas qualified and experienced social workers, it was all about, you know, focusing on learning and coping and gaining support, and, you know, being adaptable, etc. But you know, the students were expecting to be given this information in order to emerge from the course a fully resilient individual, able to cope with all the challenges of the job. Moving on, just a brief summary now of the qualities that we found that have been associated with resilience, and, you know, associated with well-being also. So these key individual personal resources here. Emotional literacy, we like to use the term literacy rather than intelligence because, you know, as a psychologist, I'm well aware, you know, that the term intelligence has been used in all kinds of ways that justify inequalities. So emotional literacy, self-efficacy, emotional self-efficacy, feeling that you're able to manage your own emotions and try to manage the emotions of others, which is a really important part of health and social care. Also to be able to regulate your own emotions, to identify the type of feelings that you are feeling, to make them clear to you and to be able to manage them. Reflective ability, again, you know, anybody working in health and social care education will say that reflection is such an incredibly important part of the training process. But certainly what we found was that if students came into social work without this threshold level of reflective ability, they found it very difficult to develop it further. So that did need to be in place, you know, at recruitment, otherwise they would really struggle. Also, this notion of bounded empathy, which is associated with reflective ability, where you need to be able to try to take the perspective of other people. I'm not saying take the perspective because we can never know. And, you know, sometimes if we think we do, it's quite dangerous in lots of ways because we don't know what people are feeling and experiencing, and to show them concern. But the risk factor is when this empathy spills over into empathic distress. So that then predicts mental health problems and burnout more generally. Psychological and coping flexibility. No one coping style did seem to be particularly effective, but it's having this wide repertoire of coping strategies that you can draw on, a little bit like a toolbox of coping styles, you know, that you can select the right one for the particular situation. Social support, again, was key, having this wide social network, both within the job, from colleagues and managers, but also outside the job. Where you can receive different types of support, like, you know, emotional support, but also concrete support for work problems. Self-compassion, really, really important predictor of resilience and well-being and health in general, where you feel as compassionate towards the self as you do towards service users or clients. And that can be a big problem for people working in health and social care. They often see self-compassion as a kind of indulgence or a luxury when we know that it is essential. So we need to make sure that people are starting off in training, you know, by being reminded how important self-compassion and self-care is. And finally, recovery behaviours, you know, looking at the work-home interface, the importance of how people separate their work and their personal life. Rumination can be very damaging, where people are continuously thinking and worrying about particular service users or situations, etc., and that then stops them switching off and recovering their physical and emotional resources. And, you know, it obviously impairs work-life balance. Moving on, just a little view really of some of these papers that I'm drawing on in that previous slide. And if anybody does want any copies of these papers or reports, just get in touch with me. And at the top, there's a little sort of photograph of the book that we published a few years ago. So what about organisational resilience? I've talked a bit about individual resilience, but, you know, I did emphasise the importance of organisations supporting individuals. So our process over several years essentially was we really wanted to emphasise co-production because, you know, I'm not a social worker. My colleague Louise Grant has been a social worker and a social work manager, is now an academic social worker. But obviously you do need to sense check and you do need to get this kind of information from the bottom up rather than the top down. So we wanted to make sure that we involved social workers at all levels at every stage of this work. So we had workshops in these workshops, we identified and refined the knowledge, skills and abilities that managers and organisations should have in order to support resilience in their organisation. We then developed and piloted a diagnostic tool, which I'll talk about in a little bit. We prepared a workbook and we reviewed the tool and the workbook over time. We launched the materials and piloted in a small number of organisations, and we then rolled out and we are evaluating it at the moment. So that's just an overview. What's it all about? So it's a toolkit, as I said, for organisational resilience. It provides social work organisations with this accessible, research-informed diagnostic tool. And what they do is they then send it to their employees, who then complete it, and Research in Practice, who we work in collaboration with, will then provide a kind of framework based on the findings, but again, I'll talk about that at the moment. So it assesses if they have the conditions that underpin a resilient organisation to support the well-being of staff and also to promote optimum practice. In this particular framework, we identified 5 principles. Now we call them Key Foundational Principles, or KFPs for short. And they are very much based on this social work specific view of organisational resilience. They may not necessarily be relevant in other types of organisation. Secure base, which is obviously a key issue, you know, where people feel that they have support, you know, to enable them to sort of do the job. A sense of appreciation, which is a key issue in all types of work, but, you know, the idea that their work is noticed and appreciated. They believe they work for a learning organisation, you know, that is innovative, but also encourages best practice based on evidence. There is a clear mission and vision that isn't just, you know, written on a piece of paper, but is operationalized throughout the organization. And well-being. Well-being is recognized, you know, the importance of well-being is recognized and managed throughout the organization. Now, these 5 foundational principles are underpinned by what we call these golden threads that should be in place throughout the organisation. Strong commitment to maintaining values and building trust. You know, social work values are extremely important in this type of context. Managing change and uncertainty. Uncertainty is pretty endemic at the moment, you know, so that's a key capacity. Making sure we involve workers in change. Cultural competence, really important again, ensuring everybody feels they belong in the organisation. Good communication and emotional literacy. So this toolkit, which is shown here, published by Research in Practice fairly recently, the 2nd edition, which has been revised to focus on COVID as well. So it's a very practical workbook, essentially, and it covers things like, you know, how we develop the approach, what the findings of the tool means to different organisations. It introduces this notion of the key foundational principles. It provides organisations with strategies for change, where perhaps they are a bit low in particular areas, like secure base may be a bit more problematic, whereas mission and vision is more satisfactory. So they are then guided to this workbook that will help them implement interventions. So there are these quick wins, you know, that you can put in place fairly easily, but also the more in-depth strategies for change. How to co-produce interventions, you know, using things like focus groups, appreciative inquiry, etc. World Cafe approaches to make sure that people are informed, and how to evaluate the methods. So this is essentially the framework in action. You know, you administer the tool using a traffic light approach. So green is like, you know, everything is okay in this particular KFP, whereas amber is like, you know, you need to take some care, and red is a cause for concern. So interventions are needed. Every organisation receives an overview for each of their key foundational, for each of the 5 principles. They use the workbook to identify interventions, and then over time, they re-administer the tool to evaluate the impact of intervention. So the idea is it's a continuous process of improvement. Just a couple of examples here. I'm not going to go through these. So this is what's in the workbook essentially. So a few core strategies that people can put in place to foster a sense of belonging, to make sure that you have a secure base, to enhance support, to enhance a sense of psychological safety and trust in your organisation, and some quick wins there, being accessible, things like open door policies, very practical, but very useful. Keeping in touch, making hot desking work and things like that. And another example of well-being. So I won't go through that, please. I don't want to run out of time. Okay, so to conclude, we're working with social work organisations across the country now. We have data from over 3,000 social workers from different specialisations, both child and family, child and family and adult social work and mental health. We are also supporting managers and leaders to target these interventions and evaluate them. I've recently written a set of guides to actually respond to challenges as they come up, because obviously working at home and dealing with service users issues at home has been problematic for social workers, and many now are moving into a hybrid form of working that they've never really had to deal with before. So, we are helping with that. And I've got a self-care resource for individual social workers being published soon. We're doing some training on building individual resilience as well in many different local authorities, and now working with Health Education England because we've adapted this framework to be relevant to people working in care homes, which I'm sure you would all agree, are struggling, and they do need some support. Okay, so that is me. I'll stop presenting and hand you over to Lucy.
Thanks, Gail. It's fascinating to hear all about the social work aspect, and I think there's so many parallels with the stuff that I did in general practice there. Almost your first slide could have been my first slide. I think it's not the research approved method, is it? But there's so many similarities that it's quite startling. So I'm coming at things from a very amateur academic perspective. I haven't got Gail's credentials in any sense. I'm just what I would describe as an ordinary jobbing GP. I work in West Midlands, which specifically I work in Dudley, which is quite a deprived area of the Black Country, post-industrial sort of environment where people are living and working. So yeah, I'm what you might describe as a portfolio GP. So that effectively means that I don't work full-time clinically. I do another job as well, where I'm a medical director in a local community trust. So I came to this research as my very first piece of research as a student at Birkbeck, doing a master's, and specifically where I was able to utilise at least two pieces of Gail's own research in my dissertation there. So this is based around that. If you could move on to the first slide for me, Orla, that would be great. So the context really that I came at my research from was this idea of a workforce crisis within the NHS. Now, in no means this is restricted just to general practice and general practitioners. There's a workforce crisis within many arms of health professional. I think the social worker, you alluded to that, Gail, but there's the same sorts of problems in general practice as there is in nursing and pharmacists and various other fields. This slide is really just to give you a demonstration of things in my area, but this actually maps the national picture very closely. So the bottom blue bars are the number of GP partners that work in Dudley, where I'm from. The left-hand side is 2015, and the right-hand side is 2022 March. The orange band is the salaried GP workforce, so that's increasing. Gradually, you can see there's an increase in numbers over that 7-year period, but the total number of those two bars is still declining. The grey bar represents students and training GP doctors. So while there's been rather an explosion in training numbers, this isn't maintained in career GPs. The little yellow bars are people we're trying to prevent them from leaving early and preventing early retirement. So you can see that the picture really with the total orange and blue is getting lower. So that's where I came from my research, from that kind of concern really for the workforce and the workload implications of my day job, and how resilience as an individual GP or as a group of people would apply to that situation. If you could do me the next one. I feel like a bit like Chris Whitty here. Next slide, please. So again, this just represents some of the other data that we've had from our local context. The top graph there is the average number of patients per practice. Since 2015, you can see that's just been a fairly steady increase. And that's largely because of the decline in number of GPs. So practices get larger just because there's fewer of us to look after the patient population. There's also an increase in the population totally in Britain since between 15 and 22. So that also explains some of it. The second graph is about the workload in terms of the numbers of appointments we're looking at. So this data is from my area, not Dudley specifically, but from the Black Country. So that's a 1.5 million type population that we're talking about. And you can see that this is spanning from pre-pandemic through the pandemic and then post-pandemic, that the blue appointments, which is our face-to-face delivery of appointments in total per month, hasn't really dropped massively apart from the first couple of months of the initial lockdown, March, April 2020. It's been, despite what you might read in the popular press, that GPs are doing and delivering the same amount of appointments as previously what they were, and in fact that's rising. The grey ones are the COVID appointments, and then the bottom chart is really how the appointments are delivered. So there's a dip in the face-to-face blue line, and then the grey line is a rise in the phone consultations. The orange line there is home visits, so that's stayed fairly static, but you can see that the blue and the grey added together adds up to the similar amount of appointments. If I could go on to the next one. So that's really just presenting you that kind of context of workload and difficulty within the profession at the moment. So the research that I did, which started just around about the time of the first lockdown, which was a qualitative study where I interviewed 27 GP colleagues from around the UK. There was a couple from outside England, but most were in England. And really we were focusing on the GP's perception of resilience in the workplace, how they felt as practitioners, and what their resilience felt like, and the things that might influence their resilience, and then looking at that in a kind of context of the NHS as a whole, and how we might support people in my age bracket and career to not leave the profession for the reasons that Gail outlined at the beginning, for reasons of poor mental health or burnout and so on. And we did 27 interviews, as I say, and then analysed that data with thematic analysis, and came up with some results, which I'll show you, I think, on the next slide. So there was, as Gail has pointed out, there was quite a bit of debate about the definition of resilience. A lot of the GPs felt that resilience was a personality trait, which I think has been very well debunked in the proper academic literature on resilience. That, as Gail mentioned, it's a more of a fluid, a dynamic concept that changes with you. And if you think about yourself as a resilient individual, there have always been times when you've probably felt more resilient at work and times when you felt less so. And that might be to do with the work itself, or it might be to do with the influences of your personal circumstances at that time. And I think we've also understand the concept of maybe a day-to-day change in resilience, or maybe feeling pretty resilient at work but not at home because of personal reasons, or vice versa. So the GPs felt actually that was much more about a personality, that you were just a resilient type, which was interesting. The influences on resilience that they talked about were positive and negative, and as I said, were work-related and outside of work. And echo rather Gail's slide on that topic. You had the key resilience wellbeing resources, is the way you described it, isn't it, Gail? So they came out with very similar expressions and things that we've seen in the research very commonly in all types of fields, not just in health professional research. There were lots of costs and benefits of being resilient at work, or having to appear to be resilient at work. And we found these 3 novel findings that didn't seem to appear in any other parts of academic research on the topic, which is that there seems to be a drive for GPs to feel that they have to pretend to be resilient as part of their professional duty. They need to feel that they're strong leaders in the workplace for the rest of their teams, for their patients, and showing and perhaps an outward image of resilience when internally they were not feeling particularly resilient. Another interesting finding was around the influence of social media. I'm sure you've seen in the fields where you work or study that there are quite a lot of platforms now where support groups or perhaps common interest groups spring up on Facebook and Twitter and so on. And similarly, in general practice, they have social media platforms that you can join and come up with ideas for resilience together. But the GPs actually found that quite counterproductive in a lot of cases, and it made them, they would quote the words unresilient to see how other people were behaving in these groups. And the interesting and perhaps most significant finding is the way that GPs identified the best way of preserving their own resilience was to reduce the amount of work that they did. And by work, I mean really clinical facing work, so clinical hours being reduced would be the best way that many of them identified that they would become more resilient at work. So mid-career GPs, we're talking about people that are ranging from 35 to late 50s. And these were the ideas that the way they felt that they could get themselves through to retirement without developing burnout or health problems would be to reduce the clinical working hours. And of course, that feeds into this problem of the reduction in whole-time equivalent GPs as well as people not coming into the profession to be recruited and people retiring early. So that was quite interesting too. Interestingly, none of the GPs, even though they were reducing their clinical hours, were in fact having more time off. They were often doing what I do, which is taking a portfolio career and taking jobs in other areas of medicine that would help support their interests and develop them as in their career. GPs have a very flat career structure on the whole. I came to be a partner when I was 27, and you stay a partner until you retire. There's no higher grading, there's no career progression. You're a partner and then you stay it. So I think again that's maybe a tactic for people to feel that they can vary their careers a little bit. So I'll have the next one, please. So there were lots of benefits of high resilience. And again, you referred to this one, Gail, in your first slide about how highly resilient workers you get improved patient outcomes. And conversely, if you've got people that aren't resilient at work, then that affects patient care. So that's really important. And the GPs had recognised that it was a very important outcome of high resilience, that patients would have a better experience as a result. We also know that there's organisational benefits, so practices find that they work together better, they're able to retain their staff, not just their medical staff, but their non-clinical and nursing and other professional staff as well. And of course it contributes to the personal benefit. You feel better, you've done a job well done, you're less likely to get a burnout, you're less likely to get mentally ill. You have a reserve, I suppose, of resilience for the future. That's the formatting's gone slightly, so the bottom bit is supposed to be the heading of the second column, so that but there is a cost of having high resilience at work, or at least attempting to become highly resilient or be highly resilient at work. And this is what we've seen, sometimes again paralleled by the social media platforms, that GPs are becoming more obstructive to work, saying no to things, refusing to take part in non-NHS work, for example, refusing for private work and doing private letters for people. This has a negative effect on their colleagues and the people who are working around them. Patients notice this and they feel this quite strongly as having reduced access and continuity. You know, my patients like to come and see me, but they know that I only work 2 days a week at my practice, so therefore they don't get much access to me. And I think this is becoming more and more common with this reduction in clinical hours that GPs are reporting. It's quite hard work, isn't it, to stay resilient? The consumption of resource in terms of sort of finance, hours, and also that human cost, the human resource to the personal GP to maintain that was definitely noticeable. So next one, please, Orla. Thank you. So For me, it was quite startling really to see how people were feeling. I mean, it was partly done in the early part of the pandemic, so I accept that may have had an influence on people's general mental state, and they were having to adapt to a new way of working very quickly. Suddenly, we'd gone from an almost entirely face-to-face service to an online service and a phone-based service, which is a complete change of practice for many colleagues, and many of them had never really trained in working online or on the phone. So again, similar to what you commented about with your social work groups. But I think we can fairly confidently say that more resilient GPs may mean a less resilient NHS. So all these GPs that are going off and doing things that enhance their own careers or reducing the clinical hours may mean that the organisation as a whole, and certainly the smaller organisations within the practices themselves, are less resilient services for our patient care. We've already spotted the workforce implications of a poor recruitment into the trade. We obviously can work out the implications on workforce of early retirements and attrition to other countries and things because of the stress of working within the NHS environment. But I don't think the NHS really has its eye on this idea that the middle-aged workforce, that is the bulk of the workforce, is also having difficulty maintaining themselves in their full-time careers. This implication that I find, I think again you referred to it a bit, Gail, about this resilience as being a personal responsibility, is very strong within the GP profession, and the GPs talked quite passionately about how they felt that resilience is just being foisted upon them as just another job that they have to do. They have to demonstrate their resilience, they have to go through resilience training, they have to do resilience tools to make sure that they're resilient, and it just feels like it's just something else to do in a very busy day, very busy life. And that if you're actually not feeling very resilient, you're pretending to be quite resilient because the perception of not being very resilient is perception as a failure. And I think maybe some of that comes back to this idea that the GPs had around resilience being a personality trait, that you're just not good enough if your resilience is low. You're the wrong sort of person for this job. You haven't got a stiff enough upper lip, I guess. This idea about obstructive behaviours that I talked about a little bit before, they may well be self-preservation strategies, but they're really quite contrary to the image of what people perceive about GPs working in their patients' best interests. And again, I think that felt, as very personally, it feels quite counterproductive to have to say no to things all the time. And when a patient's asking you for a private letter because they need it for court or benefits or something, and you say, no, we're not doing that anymore because we're not doing that non-NHS contracted work, this feels very difficult to deliver as a message to our patient group, and I don't think it does anything to help us and the perception of GPs at the moment in the public eye. And there's this social media platforms thing where this kind of obstructive behaviour is encouraged, and almost people share tips of things that you're allowed to say no to and not, sort of is there to try and support resilience, but actually makes people feel uncomfortable. GPs want to be working in their patients' best interests on the whole. Most of us came into the career because that is our aim. So those kind of attempts to support resilience may in fact deliver the opposite for some colleagues. So my final slide is just a little bit more about how we might take this forward in research. And I was interested to see your idea of this SWORD tool that you've developed. One of the things I found when I looked at the research previously done on resilience, there isn't really a lot that is GP specific. There's a fair bit that's health professional specific. There's some nursing ones, there's some psychiatry ones. There's obviously some social worker ones. And I don't know how many of the tools can really be transposed to other professions. I think there's a high chance they probably would be, but there may be some career-specific aspects that need to be validated. So I think it would be really useful to do the similar exercise to what you've done, Gail, in terms of developing a measure and a toolkit that could be used in the context of GPs in the NHS to be able to assess the benefits or not of these many kind of resilience interventions that seem to be on offer at the moment. We've got lots of people, private companies largely, that sort of come sniffing around offering us expensive courses that we can take to improve our resilience. There's something bigger about the barriers that maybe that's a professional thing, maybe that's to do with doctors as people who perceive themselves to have a little bit of a godlike status. They have this stigma and stigma associated with showing low resilience. So I think we need to work out how we can overcome that for people in that type of profession, because if you're not up for admitting that you're feeling that your resilience is low and you need to have some input and support, then you're not going to get the help that you need. And very typically, I think you would find people that need this resilience training and interventions the most might be maybe the least likely to come forward for them. So we need to work out a way of overcoming that. As you referred to, again, it's an organisational responsibility, isn't it? It's not the responsibility of the individual as such. If the demands of the job are the thing that are causing the problems of the low resilience in the first place, then maybe if we just address the cause, that might improve the resilience overall. When you're looking at the demand resource model for resilience there, you can see that the demands probably far outweigh the resources in many other cases. And I think we also need to think about how we focus on clinical professionals in general in their mid-careers. So this, I think, would apply very equally to social workers, to understand how we can retain them in their practice. Yes, it's one thing attracting people in at recruitment, and it's one thing preventing retirement, but we need to look after our workforce that are on the job right now and understand how we can take a more strategic approach across the NHS to support these people to get through to their retirement in a useful way, and also to be able to deliver the service that they had intended to when they started out. So that's really a bit of a whistle stop through my research. It was an interesting journey to do it. As I say, I'd never done it before. It was very interesting to do a qualitative thing online completely, which originally I'd intended it to be a face-to-face thing. But yeah, I managed to get it published in the British Journal of General Practice, so I was quite pleased about that. I'm not going to go on and do any other research yet. I'm just back on my day job at the moment. But yeah, I would definitely consider it in the future. So keep going, students out there in the audience. You get there in the end.
Absolutely. That's a really good final words from Lucy there. Thanks very much, Lucy. Really interesting work and so important and so novel as well. I mean, looking at it from this perspective, and you know, I've written down quite a lot of points, I think, that have emerged from your work. Now, can everybody see me? Because I can't see myself. Yes. I think because I dropped out and came back, I seem to have lost my camera.
Looks like a few have had struggled to get in and out. There looks like there have been people having to reconnect repeatedly. So
okay, fair enough. Okay, so we do have a question here, a couple of questions actually from Liz Skelton, and I think if we take the second one first, because I think that's very relevant to Lucy's talk. Did you find any differences between genders?
I did not. No, I mean my study, I can't remember the exact numbers, but it was 2/3 women to 1/3 men on the whole. Again, that might have been a self-selecting group, and we discussed this in this paper about how that may have introduced bias. But no, it was a universal experience really for across the professions. Everybody was saying the same thing, and that's fairly unusual in a qualitative piece. You get a bit of a stretch of opinion. Again, that may be an illustration of bias in the study, but no, I didn't see, and we didn't see any difference. I don't know about in the social work stuff.
I think you're absolutely right, because what tends to happen in my experience of researching different occupational groups is it isn't the gender, it's very much the position that people are in. And, you know, men can be overrepresented in, you know, promoted posts and seniority. So, you know, we need to be careful what we're looking at. And we may be looking at other factors, not just the gender, if that makes sense. But again, you know, health and social care in certain levels does tend to be female dominated, doesn't it, in certain types of work? What about GPs? You know, sorry to put you on the spot here. You may not know this, but
the proportion is shifting. It's traditionally it has been a male dominated profession, but there are more women in medical school now than men, and there are more women exiting medical school now, and there are more women training in general practice than there ever have been before. But I think the split is around about 50-50 still. Certainly there are more men that work full-time in clinical practice than there are women, for the obvious reasons. You know, women are more likely to be caregivers, and that, you know, that goes across even the professional careers as well, doesn't it?
Yeah, or trying to be both.
Yeah.
Juggling both responsibilities, I guess. And another question that Liz has posed. Thanks so much, Liz, for all these questions. They're wonderful. I can see Caroline typing as well. That's great. But this notion about testing for resilience at recruitment stage. Now, I'll initially answer that because it's something that we've thought long and hard about it, because it does seem to be a bit of an ethical issue. But certainly what we found is that, we know that resilience is something that can be developed to a point. So, of course, if we're knocking out a high proportion of people, or, even a moderate proportion of people that want to be social workers or nurses or whatever at a very early stage, because they don't have these qualities, we then, we're not allowing them to sort of develop. And we know they can develop. But there is a qualification here in what I said about the reflective abilities. So, there is a baseline level of reflective ability I think you do need. So maybe in terms of testing for resilience at recruitment, that is something that we should be looking at. Is the capacity for reflection there? If it isn't, or it's at a very low level, that may be a particular problem. So, that's something that we could think about, certainly. Lucy?
Yeah, I can't disagree with that. I think medical school is a very traditional way of recruiting people, isn't it? It goes on A levels effectively. It doesn't really look at any personality traits or people that might be more reflective in their way of learning or the way they look at their own practice. We do know that these people make better GPs on the whole, because reflective practice is really the nuts and bolts of what we're doing. And similarly, we've had injections of people to try and bring more people into the profession. So recruitment drives, getting people quotas out of medical school that they need to deliver certain proportions of people going into general practice. But what we've seen is a higher attrition rate from those people. So,
but in terms of selection for GP training, are these sort of qualities of empathy, etc., taken into account? Or
I don't think they are. I really think it's it's examination based. At the moment, we're getting lots of minority graduates from other countries other than Britain. So it's about whether you can speak English competently, whether you can write English competently, and there's very little about your reflectiveness, your empathy, your patient-centeredness, or any of that thing. So we often don't really realise until we get them right at the end of GP training, so almost maybe 8-9 years after qualification, that they might not really be suitable for it.
Right, and that must be a big blow, I guess, for them.
And think of the money spent as well by the taxpayer on that.
Absolutely.
It's not a model for a resilient future workforce, is it really?
Because, we've been arguing for a long time for this so-called emotional curriculum that runs alongside the more sort of knowledge-based and practice-based issues, right the way from recruitment to retirement, with top-ups, etc. A much more joined-up approach, I think, for health and social care. I'm going to jump to Caroline. Thank you very much, Caroline, for your question. So this is for both of us, so perhaps you can go first. How has the current coronavirus pandemic changed the experiences of GPs and social workers, do you think?
I think for us, it's just highlighted the problem. I think it's compounded the problem. So GPs that were thinking maybe I might stretch my career out another 5 years have gone, no, you're all right, actually, I'm going to retire now. So we've seen a bigger drop off of people at retirement end. We've seen a lot more in the way of people accessing the practitioner health programs. So people finding I think particularly the narrative at the moment around the negativity that you see in the popular press around general practitioners not pulling their weight during the pandemic has been very hard to take for us. Because we don't recognise that, but clearly patients are seeing something different. So that, yeah, I think it's made things worse. I guess that probably would be expected. I don't know about in social work, Gail.
Yeah, certainly working at home does seem to be problematic for many. Many like it, but there are certainly issues that are quite problematic as well, because support, this whole thing about the secure base that I mentioned in my talk, a secure base is much more effective if it is a physical base, but often it's a virtual base now. People may struggle to be to show support. Certainly we've been focusing on promoting signs of struggle, because of course, particularly for new starters, you know, teams don't know them face to face. They don't know what's normal for them, what's usual for them in terms of, you know, they're managing emotions. They don't know their home situations, etc. So, you know, it's having to get to know them essentially online, and that can be a problem, you know, for new starters, for people living alone, also who don't have this access to support, particularly if they work with trauma. And you know, you are almost like importing trauma into your own home as well, if you're dealing with, you know, traumatic child protection issues, let's say. I was working with the BPS last year to look at ways in which social workers can, and anybody working with trauma, including the police, you know, medicine, etc., how they can avoid that or help manage that. You know, so they are problematic. Switching off again, you know, is a key issue. So having a virtual commute, if you don't have a real commute, thinking about how to do that. Let's go back now to.
There was an interesting one about sexism.
Oh yeah, yeah.
Which I thought was a very interesting point. I think you may have hit on something there in terms of maleness or male traits. There's, again, my research was very strongly, people were, they were very clear they felt resilience was personality based, and I think the research is very clear that that's not the case. Isn't that right, Gail? I mean, there may be some factors that are slightly more likely, but so yeah, I think that there may be an element of that women feel more pressure to be resilient and in that way. But yeah, that's just a personal insight rather than a research-based finding.
Yes, that's an interesting point, isn't it? But also perhaps the ability to seek help maybe more acceptable for women. Or so, you know, this idea, like you said, the stiff upper lip and soldiering on, and the hero narrative, which has been very powerful, but, you know, quite damaging in lots of ways for many health and social care staff and other essential workers through the pandemic, is, you know, the super person, you know, with their cloak, that they cannot show any kind of signs of, you know, problems and difficulties, etc. You know, raising people's expectations. And again, if you do feel challenged by that, you know, what you were saying about being the right and wrong person for the job, you know, it's maybe a problem. Susan, there's a focus on resilience while some employees have to put up with repetitive, stressful or low paid work, and lack of resilience seen as a failure. Absolutely. Agree with Lucy, we need to address demands of jobs and resources, especially across low paid sector roles. Now, I do feel very strongly about that, Susan, because certainly the research that has been coming out for quite a long time, you know, they don't really manage to access people who are doing precarious work in healthcare in particular, who are on short-term contracts, who actually work alongside people who are, you know, formally employed and don't have access to the same terms and conditions and support that full-time employees do. And, you know, it seems to be really difficult to access them, because how do you access them? Do you access them through the agency? You know, they don't have pigeonholes and things like that, you know, or email addresses via the hospital or, you know, organisation in general. So I think that is a big issue. We need to know much more about people's experiences, you know, in low paid work, etc. You know, who are often working across multiple types of job too.
Yeah, that's interesting.
Susan also mentions again regarding gender. In the NHS, we've got a strong focus on compassionate leadership, which is perhaps more aligned to women-female traits. You know, this notion of women being more compassionate, etc., and caring. And I don't know, it's, you know, how damaging is that? Is it excluding men from being compassionate?
Essentially, I think that the way that the senior leadership within the NHS is stacked, though, it's still fairly male-dominated, even in a very female-orientated organisation like the NHS. So maybe it's something that's seen as a strong focus that everybody needs to take on.
Absolutely. And the final word, I think, and I think this is quite important, by Liz, in terms of, do you think that these problems may have happened eventually, regardless of the pandemic? Because it seems to me that, you know, we were going along this route. There were recruitment and retention challenges, you know, increasing demand from patients and service users, etc., with more complex, multiple issues happening. But it may well have accelerated the difficulties. So what do you think, Lucy?
Yeah, I absolutely agree with that, nodding emphatically. I think that's across all of the trades. Really, the social work is a very similar example, isn't it, in terms of the increased population, the number of challenges people are facing, the complexity of cases, the fact that simpler stuff is no longer even seen in a social worker's caseload anymore. They're just dealing with day in, day out, very difficult, challenging and emotionally draining stuff. And I think it's right. It has, the COVID situation has just caused it to happen quicker and in greater magnitude. Yeah.
Yeah, and also I think introduced some fairly novel challenges like moral injury and moral distress that will always have been there, but you know, occurred in the extreme, I think, in health and social care, where you were unable to perhaps deliver the care that you were trained to do or thought, you know, was the way to deliver care, and the damage on the individual of that will be long lasting. But you know, thank you very much anyway. I think we need to finish, and thank you particularly Liz, Susan and Caroline for your questions. Thanks to Lucy for such a really interesting talk, and I'm certainly going to be downloading this paper and reading it myself because it'll be really important to my own work. And yes, so again, thank you